The Cannabis Conversation. A European perspective on the emerging legal cannabis industry.
Welcome to the Cannabis Conversation with Anuj Desai, where we explore the new legal cannabis industry by speaking to the professionals that are helping to shape it. Welcome back. Hope you're enjoying 2021 so far. It's all a bit nuts if you ask me. But on the cannabis front, we push on. Today we are talking about kids, which is a show I'd wanted to do for quite some time. It's a key topic for a number of obvious reasons, but one of the main ones is that children are the reason that laws have changed in many countries in relation to cannabis. As a parent myself, I can say that, I would do whatever is needed to help alleviate my children's pain, even if that meant breaking the law. So it's incredibly hard to argue against cannabis as a medicine when you see and hear how some children's lives have been improved by using it. And it also takes away a key argument by anti-cannabis activists who say adults are just using medical cannabis as an excuse to get stoned. I was very lucky to speak to Dr Bonni Goldstein, who's a leading authority on cannabis and children. And it's a really interesting episode, so I hope you enjoy it. On with the show. On today's show, I have Dr Bonni Goldstein, who is a physician and medical director at Canna-Centers. Canna-Centers is a group of medical practices throughout California that educate patients on the use of cannabis therapy. Bonni has also just released a new book, and she's the author of a book called Cannabis Is Medicine. Bonni, welcome. How are you?
I'm fine. Thank you so much for inviting me.
No, real pleasure. Thanks for coming on. Loads to talk about. The main topic of the show will be around medical cannabis in children, but why don't we start talking a bit about you and your background and how did you get into practicing medicine in this area?
So when I went to medical school, I was kind of open. I wasn't sure what type of practice I wanted. And when I did the rotation through pediatrics, I just fell in love with taking care of children. I went into pediatrics, did my internship and residency at Children's Hospital Los Angeles. I was chief resident there for a year. And then I was a bit of an adrenaline junkie and went into critical care transport medicine, taking care of very ill children, moving them from, maybe a minor hospital to a tertiary center, that kind of thing, which then I transitioned into pediatric emergency medicine, where I practiced for about 13, 14 years, mainly at a large training hospital in Los Angeles called LA County USC Medical Center, and then at some other ERs as well. And I was just burned out. I mean, it takes its toll when you're working those crazy hours. And I had a child and I decided to be home during the day and work at night, and I wasn't sleeping. And it was just, all of it kind of came to a head. And I took a little leave of absence. And during that time off, a friend asked me about medical cannabis. And you have to remember, I'm in California. There was already a law in California, medical cannabis law, the first law in the United States that was passed in 1996 by voters. And it was not on my radar. I didn't know anything. And here's my friend who's sick asking me about it. And I didn't know anything. So I said, well, I'm not working right now and I'm kind of a science geek. So let me just start researching. And I could not believe what I was reading. There's this endocannabinoid system I never heard of. There's an interaction between the compounds in the plant and humans that helps maintain balance. I mean, it blew my mind. And rather than go back to the emergency room, also remember I have a small child that I would like to be around for, I decided to kind of explore medical cannabis. And I started working in a very professional practice near my home. And I just fell in love with it. And as I write in the book, I haven't looked back since. And so now I've been doing this 13 years. And I've seen probably 18,000 or more patients in the last 13 years, including probably the largest pediatric practice for cannabis. I've seen over 1,000 children.
Wow. Amazing. I mean, there's loads of questions I want to ask. I mean, one of them is around just California in general. As you said, it was 1996. So when you sort of made your decision to actually explore this a bit further, obviously you were in a particular part of the US, which was maybe more receptive than others. Nonetheless, did you still receive any kind of pushback and what are you doing? Or was it all totally fine to sort of start exploring this new area for you?
Well, look, I'm a pretty conservative physician. So when I went into this practice, I didn't really tell anybody what I was doing. I just went to work every day and just kind of kept it on the DL, as they say. I really didn't look, when you talk to patients using cannabis who are successful at it, as someone who sat in my office last year, a physician who came and sat in and wanted to follow me around, at the end of the day, I said, "What do you think?" And she said, "The results speak for themselves." Okay. So she summed it up in that sentence. And that's what I saw as well. But I just did not feel like having to justify what I was doing to colleagues and physicians who had not explored the science, who were still basing their decision on cannabis is a drug of abuse. And, look, it's when you're taking care of patients who are suffering from severe and chronic medical conditions, they are not interested in buying problems with cannabis. They just aren't. They're miserable. They're sick. They want a solution. And when you give them medical guidance, under medical supervision, you see a completely different experience than people who are purely using it for recreational purposes. You cannot compare a 15-year-old smoking cannabis behind the high school with a 15-year-old who has cancer and is facing death and chemotherapy and all the other things, nor can you compare a 50-year-old with multiple sclerosis with a 19-year-old who's, doing bong hits all day long. So let's forget that comparison. We must separate it. We have to separate it. They're not the same thing. And it's not fair to lump it all into one thing. There's medical use, and then there's what I call responsible adult use. So back in the day when I was started with this, it was still looked down upon. And luckily, I'm very happy to say, look, people have moved forward. People are now accepting the science. And I think what we have to say is the science is irrefutable.
Yeah.
Because millions and millions of people are saying the same thing. I used to joke around that patients kind of said the same thing when they came into the office after they, got on a medical cannabis regimen. Like, I'm sleeping better. My anxiety is down. I got off these pills. I'm a better spouse. I'm a better, more productive worker. Well, that's what happens when you feel better, right? And these are responsible adults. These are your neighbors, your family, your friends. They're not interested in abusing cannabis. They're interested in using it medically. And I used to joke around, they can't possibly be meeting in the parking lot and saying, let's just tell her that it works, because there's thousands and thousands of them. And they're all having a very similar experience. We have to accept that as physicians, that, this is not a pharmaceutical that can be stuffed into a randomized controlled trial, because it's multiple compounds. Everybody's different in the way they respond. It just doesn't fit that pharmaceutical model. And we want all these studies. And I agree, research is great. Let's do it. But we cannot deny the existence of millions of people benefiting from this plant.
Yeah, absolutely. Absolutely. And so what was the point where you said you were a bit secretive about it to begin with? What was the point when you felt comfortable to open up about it? Were you seeing just so many good results that you were like, I can't?
I was seeing so many patients do well. I would say it was like a 2-year kind of transition for me to finally be able to tell colleagues, friends, I'm actually working in the cannabis world and as a cannabis physician. And then what you get is the raised eyebrows and the kind of like, oh, and then I felt like exactly what I was trying to avoid. I had to justify what I was doing. Because I think for a long time there was the stigma that, and in California, look, they called us the Wild West. We had no regulations. So this law gets passed by voters and the government says, yeah, we're just going to look the other way. We don't want to talk about it. We're not going to regulate it. We're just going to continue to raid dispensaries and arrest people and, put people in jail for having large amounts of cannabis, even though they're trying to deliver it to a dispensary to help sick people. If you don't have a framework, it is the Wild West. So it's important to have the framework. But at the same time, some states now, not so much California, but outside California, it's so overregulated that patients suffering, you should see the hoops they have to jump through. Well, that doesn't help anybody. I mean, what are they afraid of? That kids are going to get it? Well, I hate to break the news to you. I got it when I was in high school. I have a 20-year-old son who could have purchased it in high school. right? Keeping it from medical patients does not keep it from people who want to use it recreationally. So we have to kind of, let's get real. And I'm not going to put up with the BS of the war on drugs. It's a big failure. Let's be adult about it. Let's allow medical patients to get their medicine.
Yeah, absolutely. And I couldn't agree with you more on all of those things. Okay, so before we get into the big topic of kids, you've just released a book I mentioned earlier. How was that whole process of writing a book and getting it out there and seeing your name in print?
Well, I wrote a book back in 2015 and I got a publisher interested, but they wanted to wait like 2 years. And I wasn't really interested in waiting a long time because California passed finally legalization for adult use and also a regulation of medical, which I was in favor of. I wasn't in favor of the taxes that they added in, but I was in favor of all products being tested and so on. So I released the book on my own, self-published back in 2016. And then look, the information in this world, in this industry and in the science of this is coming out faster than you can imagine. So I was approached last year by a publisher, Little Brown in New York, and they asked me if I could revise and update my book and can we get it out quick? And so it was 4 months, and it was funny. It was 4 months of me isolating myself before COVID hit to get it done. But I have a newfound respect for authors. It is hard work. It is so labor intensive. I mean, every, cross the T and dot the I. And I'll tell you, it's a lot easier when you have publishers and professionals helping you because they catch things that you don't catch. But look, it was a labor of love. The idea for me is not to sell a bazillion books, but it is to get the information about the science out there. We have been lied to now for almost 100 years. Cannabis was made illegal in the United States in the 1930s. It's 2020. I mean, we have the science. When you think about what they had in 1930, did they have computers? No, we accept computers. Did they have, iPhones and Androids and all of that? We've moved on. Now, why can't we move on from the stigma of cannabis and say, let's look at the science? And I think that if we wrapped up cannabis in a beautiful pharmaceutical package and we said, look what this product can do and look what it doesn't do in terms of side effects and danger, right? Nobody dies from cannabis use. When we have these opioid crisis all over the world now, if we wrapped it up in this pretty package and gave it a different name, doctors and physicians all over the world would accept it. So I think we have to, as physicians, try to put aside the propaganda and what we learned. And as somebody said to me last week, doctors are very good students. They learn what they learn, and then it gets hard to change that. And I would say that I'm probably guilty of that too. But let's open our mind to this because look, patients are going to use it with or without the physicians. It's already here. It's all over the United States. We should approach it the same way we approach any medicine. Learn about it, understand it, and I've said this over and over again. It's just another tool in our toolbox.
Yeah, absolutely. Absolutely. Lots more to come. Okay, cool. Well, let's get a bit more into the subject of children and medical cannabis. It's not a topic I've covered specifically before. I always like to sort of start off with sort of setting the scene for things in the non-cannabis world and then comparing it to cannabis. But what are some of the main sort of conditions and ailments that you're dealing with, that you're using cannabis as a treatment with? And then maybe let's look at what the conventional system is for those specific conditions.
So, really the number one condition in pediatrics that I see is what we call intractable epilepsy or treatment-resistant epilepsy. And what that means, the definition means that a child has been diagnosed with a seizure disorder, whether it be an unknown reason or a brain malformation, a genetic syndrome, or something where we know what the cause is. And they have tried at least 2 appropriate anti-seizure medications and have not they've not become seizure free. Okay. What we know from research shows that about 1/3 of all patients who have epilepsy do not respond to medications, no fault of their own. Okay. Despite the fact that over the last 20 years, we've had many new anti-seizure medications on the market. And, it's interesting. I was just reviewing some research. In the year 2000, a couple of doctors published an article showing that 47% of adults respond to the first medication tried for epilepsy. Only 13% respond to the second drug. And then there's like 1 to 4% that respond to the third drug. So you see your chances go down. And then in 2018, there was a review of all the literature, and the review showed something like 2,000 patients reviewed the same numbers despite newer anti-epileptics. And so you have to think out of the box for these people.
Yeah. So that's the first one, epilepsy. And is there other sort of things that cause spasms as well? Is it that you're looking at spasms rather and fits?
Right. Well, so seizures and epilepsy is probably number one. And then I'll tell you the second diagnosis is autism spectrum disorder. Now, both epilepsy and autism, they kind of run together. I heard a very well-known neurologist say they're on the same plane. They're both what we call neuroexcitatory conditions. It's kind of where the brain is, for lack of a better term, it's like a race car speeding down the highway and you don't have the brakes. And I don't know if you've ever heard this, but they say that like 90% of the brain works to calm down the other 10%. That's accurate. But look, we have brakes in place to control the flow of neurotransmitters, the brain chemicals that tell us how to behave. And remember that in autism, there's evidence that there's excitatory, like overtransmission. In epilepsy, we know what is a seizure? It's overfiring of neurons, right? And so both of these neuroexcitatory conditions, again, very difficult to treat. In the United States, there are only 2 drugs that are approved for autism. Both of them are antipsychotics. They do not treat the core symptoms of autism. They treat the irritability of autism. So basically, to me, it's like, here's a tranquilizer for your kid, right? But how does that help the child? That helps maybe the family or the school, then the child's not running around out of control. But to me, that's not good enough. Why don't we want something that might enhance the child's life, make the child happier, help with communication, help with social behavior, help calm the tantrums, and allow the child to engage in a better way socially and with their family? And that is what I have seen with cannabis, not in every patient, but my goodness, that's why there's this big, online presence of moms and dads saying, oh my gosh, let me use it for my child with autism. Right? Don't make us criminal for using it. So what's interesting, I want to make sure I put this out there. There is evidence, and it's compelling evidence in the scientific literature that shows that the control of neuroexcitation falls under the endocannabinoid system, where these compounds actually interact. And so there are studies that show if you block the cannabinoid receptors that we have as humans in our brain. So what is a cannabinoid receptor? It's a lock. Just think of a key and a lock, okay? We make serotonin, it's a key. We have serotonin receptors, that's the lock on the cell. So when you release serotonin, it sticks to that lock. It's a key and a lock. Serotonin receptors don't recognize dopamine. That's not its lock, okay? It's like the key to your front door does not fit the key to my front door. We make compounds, and this was discovered in late 1980s, early 1990s. We make compounds that look just like THC, and they're called endocannabinoids. And this is well documented. I once had a parent say it sounds like hippy dippy science. It's not. It's well documented. Go into PubMed or Google Scholar and write the word endocannabinoid. You will find tons of articles. So we have these receptors sitting on cells all over our brain, our gut, our immune system, and other parts of our body. And the reason those receptors are there is it's a feedback loop. You release the endocannabinoid when your body's sending an off-balance signal. That endocannabinoid releases, sticks to the receptor, and tells the cell that's sending the off-balance message to get back into balance. So a very easy thing to understand. Let's say I pour chemotherapy into your body and you have overwhelming nausea and vomiting, right? And there's people that you can go on YouTube and see this. Someone takes a puff off a joint, which might not be the way I would recommend it, but let's say somebody does that containing THC. THC goes into the bloodstream, binds to those receptors, and the person in 5 minutes is eating. Now, how can that be? Because the THC is binding to that cannabinoid receptor, telling the cell in the part of the brain that's sending that over message, feel nausea. You've been poisoned, feel nausea, throw up, right? That chemo is poisoning you. It's telling that cell, stop sending that message. And so it's very simple. We do not have an endocannabinoid system for the plant. It just so happens we have the plant. We have the system because our body developed that. And the key understanding is that the system exists to repair, protect, and for recovery. Football players, well, United States football, right? American football, they get hit on the head a lot. There's studies that show that when you have a head injury, your endocannabinoid system goes into action to protect your brain cells. So we know that people who have a stroke, their endocannabinoid system goes into action. So any trigger that might tip the boat over, the endocannabinoid system is supposed to respond and bring it back into balance. Now, here's the thing that just makes so much sense is that children with autism, just recently, 2018 and 2019, a study out of Stanford University here in California, a study from Israel, shows that those children have lower levels of endocannabinoids. So their brains send imbalanced messages without the feedback. Fascinating, right?
Yeah, huge.
Yeah.
So I've had a couple of other guests on the show, Dr. Rachel Knox and Professor Mishulam and Ethan Russo as well, talking about the endocannabinoid deficiency as often a reason for many ailments.
That's exactly right. And epilepsy and autism are two that we actually have evidence for, because I cannot just stick a needle in your arm and draw blood and measure your endocannabinoid levels. They're not really available that way. Now, they were both Stanford and Israel figured out a way to test for it. It's very complex, but you have to remember, you make these compounds when you need them, your body uses them and then destroys them. So it's not like they're just floating around. And the way to kind of look at the plant is to look at this as just an external source of augmenting the system, helping that system. Couple of things too, chronic stress, chronic sleep deprivation, poor diet, no exercise, all of that depletes your endocannabinoid system. And I'm sure Dr. Knox and some other guests have talked about, you have to kind of take care of yourself so your endocannabinoid system is functioning well. But what if you're a person who is missing some of the enzymes that make your endocannabinoids? So there was a brilliant study that came out about a decade ago that showed that people who had brain surgery for seizures, who donated a piece of that tissue, that epileptic source of seizures from their brain, were missing some of the enzymes that make endocannabinoids. So this could be something, when we meet people who have schizophrenia, people who are more likely to get PTSD, we can't go in and take pieces of their brain to study. We just don't do that. But certainly being able to measure the endocannabinoid system would be really a terrific way to be able to know who might be deficient, to identify, right? But we have that now with autism, and it's preliminary data. But for families that are struggling and suffering, especially a child, look, on average, when I reviewed my data and published an article about 3 years ago with a neurologist from Seattle Children's Hospital and Dr. Dustin Sulak, who's a well-known cannabis doctor in Maine, we gathered our data and we saw that, cannabis really helped these patients. And what we found was that some of them needed THC, not CBD, because THC is the one that really replaces at that endocannabinoid system. And CBD kind of works kind of as a traffic cop at the receptor, kind of on the side, and also has a lot of non-endocannabinoid system targets. But when we look at the overall numbers of patients, that when somebody says, this is helping me, it's not magic, right? Where is it working? Well, it's working in the brain, and it's helping to balance that endocannabinoid system. It's really important to understand that this is considered valid science and accepted by many, many people in the medical and scientific community.
Yeah. Very useful to highlight all of that stuff. And one of the interesting things about keeping the endocannabinoid system healthy, which Rachel talked about on the show, was I think omega-3 and 6 are important for that system. And one of the beautiful pieces of circularity is that hemp seed is very high in omega-3 and 6. So I love that kind of perfect.
That's right. Mother Nature gives it to us, right? And remember too that I'm old enough to remember back, I went to medical school in the 80s and early 90s. What are doctors we were on this kick to protect your heart. Don't eat fat. Everything low fat this, low fat that. You need fat to feed your endocannabinoid system. And so here we have 30 years, we're doing 20, 30 years of people saying, oh, I don't eat fat, right? But what do you replace it with? Sugar. And then what happened? We got patients with obesity, diabetes, hypertension, a whole nother slew of issues that when you look back at our ancestors, if you look back at pictures from back in the day, obesity was just not an issue,
Yeah, it wasn't. So you've said seizures and autism. Is there another big area that kids are particularly?
Absolutely. So cancer patients, remember, children get cancer. If you think they don't, go to a children's hospital and they all have cancer wards. Leukemia, brain tumors, rare cancers. I have seen kids, they say 400 a year, and I've got 8 kids in my practice with that kind of cancer. So what's interesting about cancer is that cannabis can definitely help with symptoms of the cancer itself and side effects from the cancer treatment. There's preliminary evidence that cannabinoids, the phytocannabinoids from the plant, THC, CBD, and so on, can work synergistically with certain chemotherapies. Not all chemotherapies have been tested, but there's evidence that the combination of, let's say, cannabinoids plus the one particular drug that there's a nice article on, gemcitabine, which is used for various cancers, and it doesn't have a very great result on its own. The combination synergistically kills more cancer cells than the chemo alone. There's also a number of studies. I think there's now 4 or 5 studies that show that when you take either THC or CBD or both at the same time as radiation, there's enhanced cancer killing. And then phytocannabinoids on their own have been shown to kill cancer cells in animals in test tubes. Unfortunately, because of restriction of research, there's one study from Spain from 2006, I believe. And then there's a pharmaceutical company in the UK that is currently treating patients with glioblastoma multiforme, a very deadly form of brain cancer, that they took about 20 patients, split them in half. Some got chemo only, and some are getting THC plus CBD in a 1-to-1 ratio with the chemo called temozolomide. And at a year, what they're showing is that there was an 83% survival for the group getting combination cannabis plus chemo versus I think it was 56% for the group on chemo alone. If I get diagnosed with that cancer, I will be taking THC and CBD along with my chemo. Now, the big problem, of course, with pediatrics is that there are no studies. So, oncologists, of course, are still very reluctant to encourage patients or even talk about it with their families, these families of children with cancer. But when someone's facing, they're relapsing and they've been given poor numbers, it's their child. Why wouldn't we try cannabis knowing what we know? We know that cannabinoids can cause cancer cells to commit suicide. We call that apoptosis. Can inhibit cancer cell growth. It can stop metastasis or inhibit metastasis and also inhibit what we call angiogenesis. Remember, cancers build their own blood vessels to feed themselves. And there is chemo out there that stops the mechanism of action is to stop that signaling. CBD and THC have both been shown in animal studies and in test tube studies to stop the growth of the blood vessels. And so that kind of starves the cancer. So look, I have my patients, we got very lucky. We added cannabis and I had patients coming to me on palliative care. I write about a boy in my book. His name is AJ. His oncologist sent him to me. She was open to cannabis. This is 5 years ago, 2015. And she sent him to me for pain relief. And I said to the parents, look, I'm a mom of a teenage boy. Let's go for it. Let's try. And he happened to be on a chemo. There is a study in animals that shows synergy. And within 3 months, this child had no cancer in his body. He had over 20 tumors in his chest. He had bone tumors. He was on high dose opioids. Within a week, he was down off the opioids. And the parents were very, very skeptical to start off with. But, when your child's dying and your doctor says, get your affairs in order, you're going to do anything. And I make it very clear to my patients that I don't sell the cannabis, so I don't profit if they buy it or not. Okay. So to me, it's at least worth a try. But always I tell people, if it looks like it's a bad prognosis from the beginning, don't wait till the end, because sometimes you're not going to win that war. So, some treatments, like right now, childhood leukemia has a very high rate of survival. And I can't say that about cannabis. So we have to be very clear about what we say to patients. I don't use the cure word. What I say is, I've had some patients have life extension with what we call no evidence of disease. There's a little girl that has a bone cancer that came to me June of 2019. Her doctor said she would not see September of 2019. Well, it's November 2020. She's still with us. She's still fighting, and she has a pretty good quality of life. Her cancer shrunk by over 90%. We never got rid of all of it. And the question is why? How come it worked in this one boy with bone cancer, this other? Let me do the research. Get it out of Schedule 1. What are we afraid of? Saving lives? I mean, come on. So we have to be very careful, because I would love to be able to say to a family, oh, I've treated 10 patients and we had a study and this is what we found. The same way you can do with chemo and the same way you can do with other drugs. So, yeah.
And it's great that you mentioned that the need to be balanced and real about it, rather than sort of, I guess, it's like everything, it's not perfect, and we've still got so much to learn. And I've had Daddy Mary on the show as well, who highlighted a lot of the things you just said. In one colon cancer he was working on, cannabis had amazing effect on it, but on a different type of colon cancer had no effect on it at all. And he was just sort of saying, this is just an example of how much we have to do here, how much work there is involved.
There's a tremendous amount of work. Yeah, absolutely. And, those are the main three conditions that I see. So epilepsy, autism, cancer, but there's other patients that come: attention deficit disorder, Tourette syndrome, tic disorders, GI conditions like Crohn's disease, and so on. And again, I can't go through all of the literature, and that's why I wrote the book, but there's clear-cut evidence that cannabis has this astounding medicinal benefits. And again, one of the reasons I think it's certainly safe to use in children, I'm sure, as some of your other guests have said, is it's very well tolerated and it has a very excellent safety profile. You can accidentally take too much and you're not going to end up in an emergency room. I think what people have to kind of shift gears is that most medical patients are not using THC only. They're using other cannabinoids as well. So in children, we use a lot of CBD. We use also THCA, which is the raw form of THC, so unheated plant. It's anti-nausea, it's anti-inflammatory, anti-cancer, it's an anticonvulsant. And if CBD doesn't help, or it's not affordable in the high doses often needed for epilepsy or autism, THCA can work really well. Sometimes I start children on THCA and I don't even go to CBD because of the cost. We have CBDA now as well, raw CBD, and that's being researched quite a bit. Right now, it has tremendous anti-inflammatory potential, and it's also incredibly anti-nausea. I do still have some adult patients, and I recently had an exchange with one of my adult patients fighting breast cancer, who I've been following for a long time. And she was on high-dose THC, and she started a new chemo regimen because her tumor markers were starting to tip up, and the THC just wasn't stopping the nausea. We added CBDA at low dose, and it stopped the nausea, which is terrific. And that's without feeling intoxicated. So that's the other thing, is that these other compounds are not intoxicating. We also have CBG, cannabigerol. I've seen cannabigerol help with anxiety, inflammation, pain, antidepressant. In children with autism, it seems to help a lot when you do combination cannabinoids. So, about a third of patients surveyed with this nonprofit that I work with, they found that adding CBG enhanced speech in nonverbal children with autism. I mean, imagine that.
Huge.
Right? And so they say, well, what's it doing? Well, CBG, THCA, CBDA, significantly understudied compared to THC and CBD. So there's this huge world of research waiting to be done. And, I just hope that somewhere along the line, more scientists become interested, because we need that research done, and we also need the freedom to be able to do human clinical trials.
Yeah, there's a lot there, isn't there? I mean, you kind of highlighted a couple of these bits, but in general, what are the extra considerations as a physician you need to think about in relation to children as opposed to adults? And I can imagine with something like cannabis, not that you would ever perhaps advocate smoking cannabis even to adults, but vaping, I'm sure, is a method of delivery that adults might use. Perhaps that's not appropriate for kids.
Right.
How do you manage all of these sort of things that are
Right.
specific to children?
Yeah, great question. So one thing before I forget, always, because of course these children are some of the sickest of the sick, you must look at the drugs that the other medications are on and look for drug-drug interactions. So that goes without saying. And then in terms of delivery method, the vast majority of pediatric patients are taking their oils as a liquid, either what we call a tincture or an oil extract. We kind of cross over with those words. They don't necessarily mean their exact definition. Tincture by definition means there's alcohol in it. I do not recommend alcohol-based products to my pediatric patients. So usually it's the extract of the cannabis plus either olive oil or what we call MCT oil, medium chain triglyceride oil. Some other oils are being used as well. And the oil allows you to do a number of things. One is be accurate with dosing. If you use a little, what we call a 1 milliliter syringe, you can dial in a 0.5 ml and have a really accurate dosing, if, of course, with a tested product. Meaning if you wanted to give 0.5 milligrams of THC, you could do that. That would be really difficult to take a puff and know that you're taking 0.5 milligrams. It would be really hard with an edible to cut it into the tiny little piece and take it. Okay, so tinctures allow, or liquids allow, for that accurate dosing. It allows parents to hide it in food because it's yucky tasting for the most part. And good luck getting that into a child who has an opinion about the taste, right? And then the other thing is that some of my patients have feeding tubes because they don't eat by mouth, and that allows the oil to go through the feeding tube. And it's just as effective, I have found, when it goes through the feeding tube. So the vast majority of kids are using it that way. I do have some children with autism taking edibles because it does give more of a longer lasting effect for certain patients. So the patients don't have to always medicate, frequently. And then very rarely I have used vaporizing in patients who need an immediate response. So there's a young gal I take care of she has a genetic syndrome. And for whatever reason, she has severe migraines that just debilitate her. And we have found that a maintenance regimen has reduced the frequency significantly, but she still has the occasional breakthrough. And for that, and she's 13, she has a little vaporizer, and it's immediate relief within 3 to 5 minutes. Why let her suffer for 2 hours waiting for the oil to kick in, right? And then a handful of my teenage patients with autism who still have the occasional breakthrough, behavioral tantrums or aggression. Look, when people think about autism, I've had families come in with bodyguards or a large person to control their child. I had a mom that came in with a teenage son who had 2 state-paid, for lack of a better term, bodyguards to protect her. She was a small woman, big kid, covered in bruises. And in order to keep the child in the home, she had to have help. And it's devastating. That mom had a vaporizer, and she could put the little mask over the child's face, just like an asthmatic gets a breathing treatment. And within 5 minutes of a combination of CBD and THC, he was happy. He wasn't stoned. He was calm. It sent the message to the brain, dial it down, right? You don't have to express yourself this way. And there's even videos online that you can look at where people don't want to put their children in a residential treatment center or in a facility. They want their children at home. And why should we care what medicine keeps that child at home, especially if it's Mother Nature medicine and it helps?
Yeah, absolutely. Thank you for that. It's a great sort of summary on the different ways that you prescribe in terms of delivery method. Are there any risks to cannabis with children, and are there any situations where you don't advise, prescribing cannabis for kids in those particular scenarios you mentioned?
Yeah. So, of course, if a child's on a drug, especially a cancer drug where CBD can interact with about 60% of pharmaceuticals. There's articles online if people want to read about it. CBD breaks down in the liver and kind of competes for space in the liver with about 60% of pharmaceuticals. So what that can do is if CBD blocks the metabolism of another drug, that drug can build up in the body. And that, especially with certain cancer drugs, can cause toxicity. Okay. We also know, like children aren't really on blood thinners, but adults on blood thinners, we know now there's a case report of both CBD and THC blocking the breakdown of a certain blood thinner. We have to be careful. So when we talk about risks, parents of children who are sick should make sure to go over with a medical professional the drugs that their child is on. Don't just start cannabis. And I'll be honest with you, most parents, even if they start CBD, they're afraid to go to high dose, which is usually where the drug interactions take place. 100% of patients coming into my practice who have tried CBD before coming in are underdosing. So you don't really see it as a true problem, but I don't want anybody being harmed, right? And it's an indirect harm. It's not CBD causing direct, but my goodness, we want to be careful with those other medications. I am a fan of THC in my patients. However, THC is always part of a regimen of other cannabinoids. And why is that? THC is the only cannabinoid for which you're going to develop tolerance. This is as far as we know so far. Okay. The other compounds do not cause tolerance. CBD, in fact, has been shown to help minimize the development of tolerance. What does tolerance mean? Tolerance means that you need a higher dose to get the same effect. And the reason that happens, remember I talked about the receptors on the cell wall? If you inundate those receptors with THC, those receptors migrate into the cell and hide, and the THC can't reach it anymore. So for a medical patient, what that means is you have a loss of medicinal benefits. Why am I going to put a child on THC by itself and in 3 months lose benefits? That makes no sense. Now, I have children with severe autism, likely severe anandamide deficiency, who take big fat doses of THC, but they are usually on other cannabinoids as well to enhance, I'm sure Dr. Mashulam talked about the entourage or your other guests, to enhance the synergy, but also to allow that medicinal benefit to exist without the development of tolerance. No parent wants to stop THC for 2 weeks or even for 2 days, because it's a miserable 2 days when your child resorts back to kind of their baseline chemistry, which may include aggression or self-harm and that kind of thing. So this idea that these kids are just getting THC all the time is kind of unfounded, especially under medical supervision. And I bring that up too when people talk about medical risks. What about schizophrenia? There is some evidence that in a certain genetically predisposed group of teenagers, if they overdo THC, they may have an increased risk, I think 4 times higher, of schizophrenia, especially, again, when I say genetic predisposition exists, somewhere in the family. This is not a medical patient. We don't give 13-year-olds with autism massive doses of THC by itself and that for years and years. You will lose medicinal benefit. This idea of, teenagers, again, smoking pot is not the same as using a medical regimen. So I, again, separate those. The vast majority of kids that do, let's say none of the other compounds work for them and they're using THC, at least under my medical supervision, are usually taking low dose THC just as needed or at night for sleep. And they really don't usually end up with a big tolerance issue because it's not this kind of have at it attitude that we all know teenagers. So if a little is good, more is better, right?
Yeah. And it feels like it's a really good way to describe it. It's a bit of a blunt instrument in that teenage situation. And that gets conflated with a number of other situations which have no bearing. It's a very simplistic way to sort of discredit cannabis, I think, if you like, by throwing the psychosis accusation at it.
And if I could say one more thing, I have found, and part of this is I'm very detail oriented and I try very hard to stay in touch with all my patients very closely so I know what they're doing. If someone is having side effects from their medical regimen, they are likely not on the right regimen. And we need to tweak it, change the timing, change the dosing. I just don't have families saying everything's great, but my child's sleeping all day. Well, then everything wouldn't be great. if the child was sleeping all day. Now, kids with cancer who I often put on high doses because we're trying to save their life, yes, they feel sedated. Some of them have what they would explain brain fog, but also is that from the chemo? Like it's hard to sort out sometimes what's causing what. I recently had a patient on high dose THC and CBD for a grave cancer, and the child was experiencing terrible anxiety. That is likely that high dose THC. I backed up on it. We don't know the dose. Why make the child super uncomfortable? Imagine feeling anxious. You already have cancer and you already have anxiety, and now I'm making you. So we can tweak the cannabis regimen to change the side effect profile. And most of my families report to me when they're getting good results. Yeah, no side effects. I ask everybody, are you having side effects from the regimen? No. So we have to remember that this is a little bit outside the pharmaceutical range in that, taking seizure medications. If somebody said to me, my child's on a seizure medicine, the seizures are gone, there's no side effects. Why are you in my office? You got good results. Why are we going to mess with it? Let's be real about that, right? But if they come in and say, my child is falling behind at school, is still having breakthrough seizures, the medication we think works a little bit, okay, there's room for improvement and maybe we will try cannabis. And so I don't like to make these sweeping statements, but in general, what I find is if you have a partner to work with who knows cannabis, you should be able to make your cannabis regimen as a medical patient something that does not give you new side effects.
Yeah, that's brilliant. Thank you so much, Bonnie. I mean, it sounds like there's a bit of trial and error in terms of how you get to that. And, every cannabis doctor I speak to is, start low and go slow or whatever the rhyme is. But I'm sure we could get into that. And we didn't even mention terpenes, actually. So there's loads of stuff I'd like to talk to you again. But I'm conscious of time. So I'm going to let you go now, but would love to have you back on if you're happy to come on at some point again.
Of course, I'd love to come back.
Brilliant. It's been a really interesting episode. And thank you for the book as well, which I'm going to share the link to when we promote the show.
Thanks so much.
Cool. Take care. Thank you, Bonnie.